And I will.
Okay, welcome everyone, and thanks for your patience. For those of you that have been waiting online, my name is Cindy Huber, and I'm the CEO of the National Kidney Foundation of Wisconsin. I want to give a shout out to our other nonprofit partner that has helped us put together this evening's program, the American Liver Foundation Midwest Chapter. And in the room, for those of you that are in the room here with us, is Chad Dunning, who is their outreach coordinator. So thank you, Chad. We have a number of people online, and I apologize. It sounds like we're getting feedback, at least here.
We're getting echo from that, but I think it's the only sound we're going to get in the room. So you can stay muted until Brandi comes on. We'll use your speakers, okay?
Okay. So anyway, thank you for your patience. If you do have questions, we have two awesome volunteers here in the room, Merle, who is a kidney recipient, and John, who's a heart recipient, who give back to a number of organizations, but we're really pleased they're helping us with the technology tonight, which is always a challenge. Anyway, we have two great speakers, one here in Milwaukee and his colleague Brandi, who is joining us in the Green Bay area, and both join us from the Aurora St. Luke's Transplant Program. We every year try to offer a session as part of our Living Well related to letting the experts tell us what's on their mind and what do they really wish patients would ask them when they come for their annual visit or check in at their transplant center. Sometimes you'll be surprised at some of the answers. Many times we think it just involves one or two things regarding either medications or just something current, but there's a lot of components that you'll discover tonight. So I'm going to turn the program and start the program with Adam, who will join us. And thank you, Adam, very much for taking time this evening.
Absolutely. All right. Well, good evening, everybody. My name is Adam Kallio. I am the manager of the Advanced Heart Failure Therapies Clinic at Aurora St. Luke's Medical Center. So that encompasses your heart failure patient, your LVAD patient, your transplant patient, as well as our Cardio-MEMS program and Cardio-Oncology program and Pulmonary Hypertension program. So I just a little bit of background about myself. I actually started out, this is a nugget that many people don't know, in mental health. I got a psychology degree before I went to nursing school, and then worked in mental health with kids, and then decided to go back to nursing school. And from there was basically, I like to say, born in the cardiovascular intensive care unit, where I spent 7 years, and then moved over to the transplant clinic and have been there for the last 5 or 6 years. So that's a little bit of my background, just so you guys know where I'm coming from. I'll introduce Brandi just because she's on mute, but Brandi Gwidt is our lone soldier that, or actually not anymore. We have 2 transplant coordinators now up in the Green Bay area, but Brandi and Nicole, who's our other coordinator up there, run the clinic basically in Green Bay for us. That is our abdominal transplant clinic off-site location that is affiliated with St. Luke's, and they see primarily abdominal transplant patients. So liver, kidney, and pancreas transplants, pre, post, as well as liver disease patients in that area. So that's a little bit about Brandi and myself. But what we're here to do today, we're here to understand what is life post-transplant. So really kind of adjusting to what it is that you, as a post-transplant patient and recipient, need to adjust your lifestyle and whatever else, other medical questions that you may have following your transplant, whichever organ that may be. Knowing when to contact your transplant center or coordinator, that's probably the most important aspect that we'll touch on today. Oftentimes when we're working in the clinics or on call after hours, we tend to get calls later on in the game that we would have more likely preferred to receive earlier, whether it's medication change or symptom that you're having. The earlier that we get contacted is always the better. And then, we hope to answer some commonly asked questions that we as coordinators or in the field receive that maybe you may not feel comfortable asking or know to ask, but we get often, so we hope to answer some of those today as well. So, as I mentioned, when to call your transplant clinic or transplant coordinator. So really, it's any signs and symptoms of rejection. So hopefully you guys have a little bit of an understanding of what those may be. So a temperature greater than 100 degrees is definitely a sign that we would like you to call. Signs and symptoms of fatigue, nausea, vomiting, or just feeling poor in general. Those would be also signs and symptoms of potential rejection. The other piece is that it's always nice to keep in mind is, you should always call our clinic or your coordinator whenever you feel as though you felt prior to your transplant. So for a heart patient, if you feel like you have signs and symptoms of heart failure, that would be something that we would want you to call the clinic with. For a kidney patient, signs and symptoms of kidney failure, liver patient, et cetera, those are things that would be indicative that your organ is not functioning up to the standard that we would like it to post-transplant. Going through some movements here.
Go ahead and talk.
If you're moving a couple ahead. Oh, one down. Okay. Also, if you're unable to take any medications for any reason, if you are nauseous or vomiting and can't keep anything down, that would be a reason we would need to know so that we know that you're not taking your immunosuppression medications and you put your organ at risk. Refills on any medications prior to your next follow-up visit. So if for whatever reason you're out of medications, whether it's an immunosuppression medication, if it's a blood pressure medication, or what other medication that we prescribe, if you're running out or will run out prior to your next visit, always give us a call and we're happy to electronically send that prescription to your pharmacy so that you can refill your meds prior to your next visit. High blood pressure, that is a common side effect of immunosuppression medications. And that can have an adverse effect on your transplanted organ. If your blood pressure is too high, your blood vessels would constrict, and then you may end up getting some stricture for that oxygenated blood leading to that transplanted organ, and that could lead to future signs and symptoms of failure. So we would always also like to know when you're undergoing any type of elective surgeries. Obviously, any kind of surgery that you would have that would not be elective, you wouldn't necessarily have the opportunity to let us know that that is something you're going to undergo. But if you're going to have some sort of dental procedure or a laparoscopic appendectomy, whatever it may be that you're planned, you're going in a week or two, we would like to know of those things so that we can always plan ahead, give you contact your surgeon, let them know what we would need from you in terms of if it's bridging any kind of medication or holding a medication, whatever it may be. We would always like to know prior to you undergoing general anesthesia. When you're hospitalized, very often when you become hospitalized as a transplant patient, we're such a unique population that not often do providers inside the hospital encounter a patient that has undergone a transplant and may not understand the necessity to continue on with some of the medications that we have. They may tinker with some of the things that we have that aren't immunosuppression necessarily, that would have interactions with those medications. So when you're hospitalized, it's always very good idea to either tell the attending doctor that is attending to your care in the hospital, or personally call the transplant clinic to let us know that that is something that you're undergoing, just so we can avoid restarting anything that may have been stopped. And as always, as I hope to reiterate today, when in doubt, it's always good to call the clinic. Despite what you may think, you're not annoying us, you're not going to bother us, you're not going to make us feel like, or you're going to get some sort of poor treatment because you're calling us too much. We always like to hear from you guys. It makes us feel like you're vested in your care and understand what it is that you need from to keep your organ healthy. There we go. All right, on to vaccines. So vaccines are kind of a hot button issue, I think, not only with transplant world, but in general. I think if you listen to everything that you hear on the news, there's always something new about somebody saying that a vaccine caused X, Y, or Z. we always like to use science to prove our methods. So, from our perspective, vaccines are life-saving and are very necessary to preserve or prevent, rather, any illness that you may encounter. So we always encourage vaccinations, but before you would get those, we always encourage you to contact, again, your transplant clinic or coordinator prior to receiving a vaccine, so that we understand what it is that you're going to be receiving and make sure that it is something that we would, think would be in your benefit. So prior to transplant, however, there are no vaccine restrictions. We always like to complete a vaccine administration regimen depending on your transplant center. They all have different protocols. Our center is at St. Luke's is pretty regimented in that we now actually enable or task our pharmacy with administering our own medications. We give them our protocol and they administer the vaccines for us. So that's something that we are offering at St. Luke's, so that the pharmacy is very detail oriented and can keep on top of that. Not to say that we aren't, but it's just a nice service that we're able to provide. But prior to transplant, there is no contraindication or no vaccine restrictions unless we deem it necessary to make sure that you aren't receiving a vaccine immediately prior to your transplant, because there is that immunoresponse that you would get from that vaccination. So post-transplant, as I just mentioned there, we do not allow any live vaccines to be administered. It is because of that triggers such an intense immunoresponse that having a live vaccine is contraindicated for anybody that has received a transplant previously. We do recommend that all transplant recipients receive a flu vaccine. It is just good practice to cover yourself against any potential infectious bug out there that you may encounter, so that you can prevent that immune response that we are always trying to hinder. So that's hopefully something that is instilled in you guys from your transplant center or coordinator, that we give you immunosuppression medication to hopefully suppress your immune system, and any time we can avoid transplant patients encountering bugs or infectious disease in the community, we try to avoid that at all costs. So along those same lines, kind of that herd vaccination mentality, we always like to say that your family members and anybody that you live with or stay close with are all up to date on their vaccines as well. We don't practice herd vaccinations or anything like that where, everybody in the community is vaccinated, so why do I have to? It's just good practice that everybody is as up to date on their vaccines as possible. Along those lines, children who, as we all know, are not the most cleanly of people can have exposure to, that have exposure to live vaccines. So there's a couple that we'll talk about, but in general, they're not any harm to be around children that have exposed to live vaccines. So the MMR vaccine is not transmitted to other people, so we don't have to worry about that. The varicella vaccine, it's precautions if the children or the person receiving that vaccine has a rash after being vaccinated, as that rash could then transmit the infectious disease to a transplant recipient. It's similar to shingles in that regard. So if anybody has active shingles that's weeping or actively open, then you would want to avoid that individual at all costs. The rotavirus, you want to avoid changing diapers in those children that have received a rotavirus vaccination for at least 4 weeks post-vaccination, and always practice good hand washing. I think that's something that should go without saying, but you should always say. Good hand washing is always the best way to prevent infection and transmission of such. So just to touch on the Shingrix vaccine, I'm not sure how many people have heard about the new varicella zoster vaccine that's out there. We do have started to administer that at St. Luke's, but it's not always covered by insurance. So always make sure to ask prior to receiving that if you have questions that's out there. What slide are we on? So cancer, it's kind of the elephant in the room that it's one of those side effects that disease processes that can come up very frequently in the transplant population. So it's very important for transplant recipients to stay up to date on all their routine cancer screenings per cancer screening guidelines. Those should be provided to you by your transplant center. So for women, general pap and mammos are always a good idea. Colonoscopies, especially, I think every 5 years are recommended. And then your skin assessment annually is something that we'll talk about more in a moment. But in general, as I think most people know, those immunosuppression medications suppress your immune system, and as such give you a little bit more opportunity to develop a cancer later on in life because of that immunosuppression and those opportunistic cancers. So as we talked about skin cancer, they are not just pimple popper MDs. They are definitely people that can save your life and detect early skin cancer disease. So yearly dermatology visits for routine skin assessments are highly recommended. And this is because transplant patients are at an extreme increased risk for skin cancer, especially squamous cell carcinoma. So this statistic is always kind of glaring, is that transplant recipients are 65 to 250 times more likely to develop skin cancer. So that is very important to keep yourself checked and keep going to your dermatologist. They will provide those life-saving screenings. So ways to help prevent and manage skin cancer. Those are, similar to what, the general population would have. It's patient importance about the wearing of sunscreen. So, it's really just, trying to avoid direct sunlight or sun contact as much as possible. But when you do have it, wearing as much sunscreen as you can. And then routine self-skin assessments, knowing your ABCDs. So anything that you see that's abnormal, have abnormal border, abnormal color, abnormal raised impression on your skin, those are things that you would want to get checked out by your dermatologist. And then collaboration between dermatology and transplant providers on management and treatment of those skin cancers is always very important. One thing I think I may have glossed over previously, but when we were talking about medications, I want to make sure that we reiterate that if some other provider gives you a new medication or changes the medication, that would also be something that you should contact your transplant center or transplant coordinator about. Sometimes those medications may have interactions with your immunosuppression medication that the prescribing provider may not know or understand or see. So any new medication, antibiotics that you may be on temporarily, those types of things are very important to let us know about, so that we may check your level or adjust it as such, so that you don't become over or under immunosuppressed. And then smoking cessation. I think this is, hopefully a thing of the past, but I think most people understand how important smoking cessation is. It's not just important for transplant recipients, but for the general population. However, for the transplant recipient, smoking after transplant is associated with an increased risk of death-censored allograft loss. So smoking will increase your chance of losing that grafted organ. For kidney transplant recipients, it gives you an increased chance of malignancy post-transplant comparatively to those non-smokers. And for lung transplant recipients, God, I hope they don't smoke, but if it shows an increased risk of chronic kidney disease. So not only will you be hurting your transplanted lungs, but then you'll be affecting your transplanted organ as well. For heart transplant patients, heart transplant or heart disease in general, smoking increases your risk of heart disease, but it decreases your life expectancy from 16.28 years for non-smokers to 11.89 years in smokers, with an increased risk of coronary artery disease and increased risk of malignancy. So, smoking in general will constrict your vessels, and so that will, in turn then constrict the oxygenated blood that will lead to your transplanted organ. So by smoking, you're just increasing your risk at losing that transplant. So liver transplant, again, increases the mortality, cardiovascular mortality, septic mortality, and increased risk of biliary complications compared to non-smokers. So again, just that vasoconstriction and putting that organ at risk. So now I think I turn it over to Brandi, who's on.
Hi, can everybody Can everybody hear me? Hello?
There she is.
Guys, can all hear me now?
Yep. Gotcha.
Okay, so I'm going to move on to hypertension, which was briefly touched on earlier. You should always call your transplant coordinator or your primary care doctor with any persistent high blood pressure. Across all organs is kind of different. We don't usually follow the gold standard of 120/60. It's based off of what the provider sets as when you should call your coordinator. Why do we want to know about high blood pressure? Because it can lead to graft loss if it's persistently high, especially in our kidney transplant patients. If they have chronically high blood pressure, it can then lead to graft loss and need of another transplant. High blood pressure is a cause of the immunosuppression medications that most of our patients are on, so it's not uncommon that our patients will need to be on some kind of high blood pressure medication after transplant. Next. And then next, we always talk about primary care. We get a lot of questions on why do I need a primary care doctor if you're always going to be there for me if you need something as a coordinator. We recommend that all of our patients maintain a primary care doctor and have regular follow-up at least once a year. The reason behind this is we always like to have a primary care doctor to help better manage you as a patient. They can help us with any kind of consults that we can't get, or if we're in a pinch and can't see the patient in the clinic, maybe the primary care office can help us out. So if you're always established with one, it'll be easier to get in if you have, for example, a sinus infection or an ear infection or just not feeling well. They'll be able to help see you quicker than we may be able to. And sometimes we don't always want to handle those little things as sinus infections. The primary cares can handle them pretty well. Also, we like to have them on board because they help us manage any kind of diabetes, like I talked about earlier, high blood pressure, and any kind of high cholesterol. They're nice people to help us out with that. And they're the ones that usually help us with any routine health screening, mammograms, colonoscopies, PAPs, all that stuff, because then they're the ones that are handling it, and that kind of brings us back to our focus on taking care of the transplanted organ and not the normal stuff that a primary care provider can help us with. Also, they're good to have on board because a lot of our patients don't live close to the transplant centers, and we need primary care to help us if any of our patients need anything, IV fluids, or need any other extra medication help that needs to be done at a center closer to their home. Like if patients live in Michigan, it's easier for them to get care through their primary care than us trying to bring them to Milwaukee or Green Bay, for example, to get them what they need. So primary care is the number one thing we recommend our patients to follow closely with. Next slide. Mental health post-transplant. This is a big topic that a lot of our patients don't like to talk to us about, but we would like them to talk to us about because it's a problem not just with transplant patients, but with the normal population, and we can help them if they need help. Transplant patients are at an increased risk for anxiety and depression due to the medications post-transplant. Almost 50% of transplant patients experience at least one episode of anxiety or depression within 2 years of transplant, and 25% of patients will experience some sort of PTSD. So please contact the transplant provider or the coordinator, with any symptoms of anxiety, depression, not feeling well, just feeling down, feeling guilty of the experience you went through, just feeling like I am always depending on somebody to take care of me. I can't get out of this funk. We are here to help and get you the help that you need to get you feeling better and have a better quality of life after transplant. We don't want you to be depressed and down about getting transplanted. We want it to be a great experience that you can share with other people. Next slide. Exercise after transplant. We talk about this a lot, and we encourage our patients to transplant. Depending on what kind of organ you have, it will limit what kind of activity you can do after transplant. It's always important to ask the coordinator, when can I get back to a normal exercise routine? Physical activity may reduce the disease effects of the immunosuppression medications. It's not uncommon. We see this a lot from the medications after transplant, especially patients who have to be on a lot of steroids after transplant. On average, some of our patients will gain 20 to 30 pounds after transplant, and exercise is a good way to help keep the weight off. It can also help treat those things such as high blood pressure that come with immunosuppression medications, high cholesterol, diabetes. I always encourage our patients not only to get out and walk, there's the pool, there's other ways to get some kind of exercise in, even if it's 30 minutes just walking around the mall just to get something in a day. And then, a lot of our patients will work with some kind of trainer if they can, because progressive exercise programs can achieve the same high function levels as non-transplant patients. So as soon as our surgeons say it's okay, we encourage our patients to get out, get moving, and exercise, because you want to take good care of your organs and have them last as long as possible. Cost. This is a big question that we always encourage our patients to ask us as well. Please call anytime before changing any kind of insurance. This is a big time of the year that we want our patients to call us, because it's time to change insurance. We want to make sure you have appropriate drug coverage, because we don't want January 1st to hit and you to be calling us saying, hey, my medications are now going to cost me $2,000. What do I do about that? So it's best to chat with us beforehand, because we can always help you with those changes now. It's harder to help with those changes after you've already made them. Most of our patients would have to wait a whole year to make those changes and come up with the money. And, we try to work with the patients and the drug companies to get the medications that we need. Please call with any problems affording the medications. Increased risk of rejection can come from the inability to afford a medication. A lot of patients that can't afford them will, try to only take them a few days a week, and then all of a sudden they're rejection and they don't know why. And it's mostly because, we need you to take the medications every day. So please call anytime. That's a big thing. We encourage our patients. It doesn't matter if it's the weekend, whenever, call if there's any issues with medications. Next slide. Support person. This is a big thing that we encourage all of our patients to have, not only before transplant, but after transplant. We ask that our patients bring those support patients to visits with them, because they may notice something that's going on that the patient doesn't, or say, hey, do you remember this question you need to ask? So it's always good to have another set of ears to understand the process, especially right after transplant. You're learning a ton of information. There's a lot of medication changes. We're telling you a lot of stuff. Do this, don't do this, come back here. We try to write it all down for our patients, but sometimes having that extra person is always very helpful. Another big thing that we encourage is to always have a release of information on file in the medical records to discuss issues with your support person, because sometimes they'll call and they'll be like, hey, what's going on with Joe Smith? And we're like, well, we can't really tell you because you don't have anything on file. So always make sure that you have a release of information on file with whatever healthcare system you use, because it always makes our job a little bit easier, so we don't have to then call you to ask for permission to talk to the person that you want us to talk to. And go hand in hand with that is you should always have a power of attorney for healthcare filled out, just in case something would ever happen to you before or after transplant, so that we know who your decision maker is at the time that we need it. Next. Big topic, questions you're always afraid to ask us as coordinators, whether it be you're just not comfortable or what's going on. The biggest one is sexual health. This is an important thing in everybody's lives, but a lot of our patients are afraid to ask us when they can have sex again. Always ask us. We're always here. Don't be embarrassed. That's what we're here for. If you don't feel comfortable asking your coordinator, ask your doctor, or vice versa. We'll get you the answers that you need from us. Going back to work, another question a lot of patients are afraid to ask for us. I don't know if it's because they don't want to go back to work or they're not ready, but we encourage all of our patients to go back to work in some sort of capacity at some time, whether it be 3 months after transplant, 6 months, or a year, kind of whatever. Work with your coordinator, work with your doctors, figure out when the best timeline to go back to work is, and even work with your employer. What are their expectations? What do we need to do to get you back to work? Is it getting you into an exercise program so you feel stronger to get back to work? Physical therapy, getting you into occupational therapy. That's always helpful for a lot of our patients, just to kind of get back into the swing of things, especially if you work in a factory. Just try to figure that out. And then any kind of lifestyle modifications. Is there anything that I can't eat? Any place I can't go? When can I go on vacation? That's a big thing a lot of patients want to do after transplant. They want to go back to a normal life. They want to go back to a better quality of life. So when in doubt, if you have any questions, that's what we're here for. Ask us anytime, during clinic, or you can call even when it's not your normal clinic visit. You don't have to wait a year to give us a call and say, hey, I want to go on vacation. Is that okay? Those are big things, just let us know where you're going, because if you are going out of the country, or if you're going to Laos or Africa or something like that, we want to make sure, once again, that you have the appropriate vaccines to travel outside of the United States. And we don't want you to go somewhere where you're going to get really, really sick and risk losing your transplant. So that's always a big thing to touch base with us about anytime you're going to travel outside of the United States. Next. And then any questions for us?
Vomiting?
Yeah.
Is there a amount of time that you're okay that it's in your system? I've heard like 4 hours or so.
Like if you took your pill and then
like 4 hours later you throw up?
Oh, is there an amount of time that you're saying if you took your medication and then you vomited thereafter? Is there an amount of time where it's okay that it's in your system? I would err on the side of caution. If you took your pills, say at like 7 o'clock in the morning, and you threw up at 9 o'clock, I would say not enough in there. But I think you think your 4 hours is pretty close. I'd have to look at the insert depending on the medication that you may take, but yeah, it depends on the half-life or the absorption rate of the medication itself. So it depends on what pill you're taking, but if you threw up within, I'd say a couple hours of taking your pills, I would call, because that's usually not enough time for that to get in the bloodstream, especially if it's just an oral medication like that. So always err on the side of caution. Yeah.
This is Cindy, and I don't know who can answer this, but some of your comments might seem like it's for the folks 2 or 3 years out, but I assume both of you would want transplant patients no matter if they're 10 years out, and that the transplant center is always their home. Would you agree or not agree? Or
Absolutely. I mean, especially, I'm not terribly familiar with how other centers practice, but I know at St. Luke's, we like to say we get you from diagnosis to death, and that might not be, it's kind of a grave way to say it, but, we like to say that, you're our patient for life. If there's anything that ever happens, whatever it may be, even if it's non-transplant related in your life and it's a big monumental event, we like to know about it, not just from a medical standpoint, but from a personal and professional standpoint as well, So, things like, just a death in the family, getting married or something along those lines, we just like to know, just, not only does it impact your care, but it impacts you as a person. So I always say, always a patient.
We have an online question.
Sure.
You still have to repeat it.
Okay.
What are the procedures for reversing rejections?
What are the procedures for reversing rejections? So that's a good question. It's not a straightforward answer. There's a variety of medications that we would use. Some of them are, all of them, inhibit the immuno response, but they can vary from plasmapheresis, which is basically just, removing the plasma from your body, because a lot of the antibodies that you may carry lie in the plasma. So we remove that plasma from your body. We may give you some sort of IVIG, if you've heard that before. It's an immunoglobulin that we would give you to, again, inhibit that immuno response. Steroids are common, but then you get into some of those other really strong immunosuppression medications that you may have heard of: Rituxan, alemtuzumab, basiliximab, a lot of those MABs at the end of the names. Those are going to be those strong medications that really blunt your immunosuppression response that you would get. In terms of checking the efficacy of those rejection treatments, you would obviously get potentially biopsies, donor-specific antigen blood work, and then just monitoring your organ function, whether it's a liver, a kidney, or a heart as well. Just continuous monitoring to make sure that organ is functioning at its highest capacity. So not a straightforward answer. A lot of centers practice a lot differently. So, you know, you may get one answer from one center that says, you know, you should just be on a quick regimen of 5-day IV steroids, and another one will say you should be admitted for, you know, a week and have plasmapheresis and IVIG and the whole book thrown at you. So not every center practices the same way, but, you know, I think the drugs are pretty similar. And Brandi, feel free to correct me.
Nope, you got it.
Okay.
The other question, this is Cindy again, that I was wondering is the presentation talked a lot about your transplant center and then primary care, but I'm wondering if you guys have opinions and guidance for recipients or family members in terms of other practitioners like my doctor or my ophthalmologist or my dentist as it relates to some of those major procedures, because those are always peripheral and might not be necessarily connected with the system my transplant center is a part of. I don't know if that makes sense, but it seems sometimes I wind up being the communicator back to my primary care saying what maybe my ophthalmologist is doing. It seems that there needs to be a connection with some of the other things that happen with, let's say, aging or other disease processes. And I don't know if you guys want to comment about that or what you want to know about.
Sure. So I'll say a couple of things. I mean, I think, as we said in the presentation, I think if you're ever going to undergo any type of procedure, whether it requires general anesthesia or you know, just even some local anesthesia, to be something we want to know about, and that includes especially dental procedures. We always like to pre-medicate dental procedures with an antibiotic because your mouth is not a clean place, and whenever you go in and you start pulling teeth or drilling holes, that, you know, goes straight into your bloodstream and can then cause an infection and risk your organs. So always like to know about dental procedures, especially. I think, you know, to Cindy's point, those doctors that are, you know, quote unquote on the periphery that may not be affiliated with your hospital, like your ophthalmologist and sometimes dermatologist or, you know, other outside entities. You know, we like to be in the know. We're kind of nosy people at transplant centers. We like to know whatever's going on with the patient. So if it's, you know, something where you're having macular degeneration or glaucoma or whatever it may be, that may not, you know, you may not think it might directly affect your transplanted organ, but the medications you take to treat them may affect your immunosuppression levels, may affect other things of that nature. So we always like to know, you know, if something's going on with another provider or another treatment that you're receiving. But always, if you're going to have any type of procedure, to let us know prior.
We have another question online. Could you repeat the information about the new shingles vaccine?
Sure. The new shingles vaccine is called Shingrix. It's a new vaccine that was just released, I want to say, in the last year or so, or FDA approved. So I'm not terribly familiar with it. I do know that at our center we have started to administer that as part of our protocol. I know that not every that's just, for instance, that's just the heart side of things that administer that vaccine. Not even our abdominal team doesn't administer that because it's not always covered by your insurance. So it's got good coverage. It's something that we do now offer to our post-transplant patients for our heart recipients, but it's not as much out there in the general population as the others, because it's not live. It's not a live vaccine, so that's why we can start administering that.
The other thing with the Shingrix vaccine is it's a 2-part vaccine as well.
Say that.
So you'll get 2 vaccines. You'll get with the Shingrix vaccine, it's a 2-step vaccine. So you get one and then you'll get the second one. The other problem that we're running into with our pre-transplant patients is there's a shortage of the vaccine in some areas right now. So some patients are getting the first one but are unable to get the second one. So we're really not encouraging it 100% for all of our patients just because we want to make sure that we have enough of it for everybody.
To repeat my question, but I'm still back on the eye doctors, dentists, and those foot doctors and all those other folks. Do I tell my doctor, I give them my transplant center's information? Should I specifically say, send my record of this something? Can you just talk a little bit about the process?
Sure.
And I don't know if you can repeat that, please.
So Cindy just asked if, to go back to the quote unquote peripheral physicians or providers, how that process should take place when, I'm seeing that provider at an outside location. Should I ask him or her to send my records to the transplant center? Should they contact them, or should the patient themselves take the initiative? In my eyes, I always like to have patients be owners of their own care. I think that that's always the best way to ensure that those things take place and that, the patients are invested in themselves. That being said, I think it's more than reasonable to request that a provider have a conversation with another provider. I think within reason. I don't know that, they're necessarily going to need to know that you had a bunion removed, but, it might be good good practice to have everybody in the know whenever something's taking place with your overall health. So I would recommend that the patient, when they're at that appointment, to disclose to the provider that, they're a transplant recipient. Hopefully they already know that. And then, make sure that you request that they communicate with the transplant center, anything that it may be. If it's just even faxing a note from that clinic visit to the transplant center, that's fine. But if it's anything more than that, like I'm prescribing a new medication or I'm going to undergo a procedure, then I think a phone call by the patient would be recommended to the transplant center.
And I know I'm reading peripheral things, but Brandi talked about mental health. So would that apply, or would there be any other, because if I'm 300 miles from my transplant center and I choose to see a counselor or a psychiatrist, would you change your answer or add to that answer, or would it just still be patients sharing that to let you know that I might have entered counseling, as an example?
So to repeat Cindy's question, it's if the patient sees a behavioral health professional and it's not in the local area or near your transplant center, should the patient still disclose that to the transplant center or coordinator? Then my answer to that is yes, with a caveat. I think you don't need to disclose everything that you discuss with that behavioral health professional. You can just say, I'm seeing this person because I want to, or whatever it may be. You don't need to say I'm seeing them because of X, Y, and Z. But, I think then again, to beat a dead horse, so to speak, if that behavioral health professional does decide to prescribe some sort of medication, that it would always be a good thing to let your transplant center or coordinator know. So I would always be, as forthcoming, and that's why I always like to say that, transplant patients are part of the transplant family, so that, anytime you undergo any kind of procedure, therapy, whatever it may be, to just let us know. It's not going to come with any sort of judgment, but we just need to know if there's something else going on in your life. So yes and no, in a sense.
Any other questions?
Well, thank you all. Appreciate it. Yes, sir.
Are heart transplants really 16.28 years?
I think now we see not quite that long. I want to say 12 is about the going rate, but we have very high success rate at St. Luke's. We have many patients that are over 20 years. So I know Bill and Diane were just at our celebration of life. I like 20. Yeah. So yeah. So I mean it's.
My 11 years in physics. months.
Congratulations.
Losing time.
Yeah, no. I think that's a 50%, 12 years. So you're doing good.
All right, any other questions? Well, Brandi, thank you very much for hanging in there with us. Adam, thank you for joining us. I just want to remind people that are both here in the room and online that our next program, I think, is going to be an exceptional program. That's on Tuesday, November 13th. For those of you that want to join us here in Milwaukee or West Allis, we're being hosted in the a great conference room that our friends at the American Liver Foundation have organized. But what makes November, I think, particularly interesting for both for recipients is showing gratitude to donor family members. And some of you are maybe have tried to communicate, and maybe that was 10 years ago. Some of you are more recent. Maybe some of you have connected to donor families. But we're going to kind of get a behind the scenes look at both how the organ procurement organization handles requests from donors' families who want to know more and potentially connect with recipients. And so what is that process that really goes on behind the scenes, and some, I think, real life experiences from some donor family members. They'll be joining us here. And on the other side of the coin, we have a social worker from a transplant program, Ginny Corco, who will describe her experiences in terms of recipients that have approached her. How she or the transplant folks have helped recipients craft different communication. And that communication doesn't necessarily have to be in writing. And then also, I think Ginny's perspective will offer ways for all of us to honor donors, whether we've connected or not. So we thought, given that November and the month of Thanksgiving, that might be a really nice discussion. So even if you have connected with your donor family and your recipient, I hope you'll come and share, because some of the folks that might be joining us in November might have given up or not know. I mean, sometimes recipients just don't know. Do you just try once? And if they don't respond, never try again? Do you try every year? Do you do it on the anniversary of your gift of life? I mean, I think recipients have a lot of questions, etc. And then, so that will end our Living Well series. So if you do have ideas for topics for starting in January, we'd love to get your ideas for that. But again, Brandi, thank you so much for joining us. You sounded great here, by the way. Adam, again, thank you for being a part of our program tonight. And thank you, everybody, for coming.